And the issues nutritional facts and functional decline in older people, what we know many things, but what we ignore more things than those that we know. I have split my talk in 4 topics for reaching final conclusions. And the first one is which is the election we now are facing. Longevity or function? Still now many people provide data about consequences of diseases, consequences of intervention in terms of avoided death, in terms of prolonging longevity. But I could show you these 2 photographs of 2 persons, 88 years old. In the left part, you have a very well-known Spanish alpinist, 88 years old when the photograph was taken. He died recently, 6 months ago, at the age of 92. And in the right side of the slide, you can see a photograph of another person, anonymous person, 88 years old, and it's in a wheelchair. Everybody wants to be like that, but nobody wants to be like this poor man. And this is increasingly relevant, taking into account something that sometimes we forget, is that there is a biological limit to human lifespan. So it's not possible to prolong significantly life length when you reach some ages. So it has no sense to measure anything when you are working with other people in terms of more years or years added to the life of a person. I would like also to check this other controversy. What is the real problem nowadays in terms of the approach to the patient? We want to treat disease or we want to improve function? And it's quite clear that as older you are, the role of disease in predicting things and in providing quality of life are going down, down, and down. And the role of function is going up, up, and up. So in our populations, function is the most important factor for the clinical manifestations of the disease, indeed for the pathophysiology of these diseases, its prognostic value and markers of efficiency. And this also marks a way of approaching any problem in other populations. Since this conceptual framework is not strange to see that some geriatricians, some experts, has started to talk about not improving longevity, not in improving health, life of years, but in improving your health span. That means the time where you are still able to do things. And the main purpose of geriatric medicine is not to prolong life, but to prolong health span. In 2015, the WHO released its first report on aging and health. And at that report, they coined one term that was healthy aging. And the healthy aging was defined in terms of the process of developing and maintaining the functional ability that enables well-being in older age. This is a change of paradigm. They define healthy without mentioning at all the term disease, not chronic disease, not acute disease, no disease. And second, put the emphasis in functioning. So according to this new paradigm, you can have 10 diseases or 12, but if you are able to maintain your functional ability, you are a healthy old person, full of diseases, but you are a healthy older person. And for this, they introduced a second concept that was intrinsic capacity. That is what I am able to do, taking into account my physical, but also my cognitive capacities. After that, some years later, several experts defined the 6 domains of intrinsic capacity. So now you can measure this intrinsic capacity. Intrinsic capacity goes down along your life, and it depends on 3 main issues. First, the aging process per se. Second, diseases has a mild contribution. And third, your lifestyles. As you age, your intrinsic capacity is going down, but is asymptomatic until you reach a certain threshold. When you reach this threshold, these losses in intrinsic capacity makes manifest. But not having clinical manifestation does not mean in any way that they are not existing. The issue is that if you wait to have clinical manifestations, probably you are late. Because as you are losing intrinsic capacity, you are losing also functional reserve. So when the manifestations of this intrinsic capacity are done, your probability of recovering is going down and down and down. And this is why we are recommending geriatricians that you need to detect the issue when still there is not significant disability and when still there are enough functional reserve. And this period of time, the pathway from robustness to absolute disability and death, is what is called frailty. You know that it's a term largely described now in geriatrics. And this is because as you are getting older, the many chronic diseases, in addition to the changes by the aging process per se, are manifested by functional impairments that go from frailty, mild or more severe frailty, and indeed for disability. So when you are assessing this functional status, you are also assessing in some way the diseases underlying these changes in functioning. And in this role, determining the things that are linked to functional impairment, nutrition plays a very significant role. Because one of the determinants in these losses of function is muscle. When there is sarcopenia, is one, not the only one, but is one of the ways of becoming frail. And for determining this, malnutrition, nutritional facts, is of the utmost relevance. We know many things. We have huge amount of data about what happened with other people regarding their nutrition and well-being in the hospital or in nursing homes. But this represents only 5% of all the population. What about the other 95% of the populations? Those living at home or attended in primary care, doing a usual life. We have a big absence of data. We lack many data about the role of nutrition on this population. 5 years ago, in BMC Geriatrics was published this meta-analysis, the first meta-analysis assessing the role of nutrition on frailty. And of course, it has main strength because it gives a beneficial outlook on how nutrition is linked to frailty, but also it has 2 big limitations. First, most of the included studies were cross-sectional design, not allowing to get causal relationships. And the other one is that the 5 longitudinal studies assess 5 different issues of the nutritional facts regarding frailty. One about diet quality, other about nutritional assessed by M&A, other about the role of antioxidant, micronutrients and macronutrients. So it's very difficult to reach fair conclusions. To contribute to a better knowledge of the relationships between malnutrition and frailty, we published 2 or 3 years ago this study when we assess the relationship of malnutrition or to be at risk of malnutrition in an older population living in Toledo, in the Partido Judicial de Toledo, where 1,600 older adults follow up with during from 3 to 5 years. And we clearly shown that malnutrition was significantly and positively associated with the probability of being frail, according to the Frailty Index, but also according to the Frailty Trait Score. So there's no doubt that malnutrition is clearly linked to the risk of prospectively develop frailty. When we go to look to the role, this same role, regarding not frailty but disability, the results are not so clear. It's really shocking that everybody talks about the relevance of nutrition on disability, but when you go to the literature, there are lacks of knowledge that are really shocking. And this is the case for the relationship between malnutrition and disability. It looks that there is a relationship, but it is not quite clear and depend mainly on the way for assessing this relationship. If you assess nutritional status by abdominal perimeter, it looks at the relationship, but when you use BMI, it's not so clear. In this regard, I would like to show you this very recent paper, the same year, showing which are the main factors associated to disability-free survival in 20,000 other people, women and men. As you can see, around 66% of your probabilities are provided by the age per se. Another 20% is by cognitive status. 13% by gait velocity. And the fourth factor involved is BMI. So nutritional status seems to play a significant role, taking into account that nor age nor gender is able to be changed. So taking into account things on what I can intervene, BMI plays a very significant role. And this is another example of what I talked to you in the early part of my presentation. Disease does not contribute near at all to this disability-free survival. What about in very older people? This is the Newcastle 85+ study. You know it very well. It's a very well-known study. And they show in 700 older people that, again, in this case is protein intake, to be well-nourished, assessed by protein intake, is associated to a decrease in delay in functional deterioration, taking into account that this population were disabled at baseline 2/3, 66% more or less. So what they have assessed is how this population is becoming more and more disabled. And they have seen that those with a good protein intake, 1 milligram per kilo, delay this functional deterioration. And this is independent of the physical functioning, or the physical exercise in which they are engaged. So we have seen the role of nutritional status regarding frailty, regarding disability, and what about death? In our study, we clearly show also that both malnutrition is clearly assessed, is clearly linked to the risk of developing death. This is quite clear. This is community dwelling older people. So not only the hospital, but also in the community, malnutrition is linked to the risk of dying. What about micronutrients? There are also several data showing that some micronutrients are related to frailty. Perhaps the two more usual factors are vitamin D deficiency, that increase the risk at 6 and 10 years. There are many studies showing that. Also some antioxidants like resveratrol. And very recently, it was published a study showing that olive oil, virgin extra, not any olive oil, but virgin extra, prevents the risk of developing frailty in older population in more than 4,000 older people in Spain, follow up during around 4 or 5 years. And you know that there is a controversy about what happened with proteins. We have data showing that proteins in general are protective, but also there are some studies suggesting that is a risk factor. Recently, 2 studies probably have thrown some light about the issue. It looks that is red meat the one who put you at risk. High ingestion of red meat put you at risk of developing frailty, while any other protein, no matter the source, are going to protect you from developing frailty. There are data from the NASA's health study in more than 85,000 other people. So I think there are very, very, very strong data. What to do? And with these 2 last slides, I'm going to pass to Dr. Soto. WHO has proposed what is called the Integrated Care for Older People program, with 5 steps: screening, assessment, performance of a health plan, implementing of the plan, and providing support for caregivers in order to improve several of the 6 domains I talked to you earlier in my talk. 2 of the 6 domains are quite significant. One is cognition, but other one is vitality. And vitality is mainly related to nutrition. If you can see in this slide, in the upper part is what to do regarding cognitive capacity, and in the lower part is regarding nutrition, regarding vitality. So WHO has proposed a clear plan on how to detect and intervene on these nutritional facts in older people. So my take-home messages are summarized in these 6 bullets. The first, the impairment of intrinsic capacity lead to loss of autonomy. There is a clear association between functional status and nutrition. Nutrition is clearly a risk factor for developing losses in functional status. Early identification of malnutrition is key if you want to reduce frailty and disability, and is core for preserving intrinsic capacity. The plan of care should include multiple interventions towards well-being and preserve autonomy in older people, and for doing this, ICOP strategy is a promising and comprehensive program promoted by WHO in order to cope with nutritional deficits in older people. And this was I want to tell to all of you. So thank you.